So my experience using Technegas has been standard of care. It's the only imaging agent that we use for ventilation examinations, which we do on a daily basis. So we may do a couple of ventilation perfusion lung scans looking for pulmonary embolic disease. Virtually as a daily examination for us. In our experience, and most Australian nuclear medicine physicians, Technegas is the standard of care. I haven't used aerosol ventilation examinations for well over 20-25 years. Xenon is not applicable in Australia. We don't use it. I think that they're both quite inferior techniques for ventilation examinations for routine lung scans. So our experience is very long and extensive, and we use it without second consideration about any other examination. When there is an equivocal lung scan, the utility of using SPECT-CT looking for non-embolic pathology is superior to planar imaging. So I use the planar imaging as a guide, but I certainly use SPECT, and particularly the CT component, to look for non-embolic pathology, which is very common, and it helps us to reduce the number of indeterminate lung scans to a very small percentage. We're now finding that we're able to cut through our message a little better with emergency physicians and primary care physicians, that they see that when we do a ventilation, perfusion, planar and SPECT-CT examination, it's equivalent to looking at a CTPA without the technical issues that can plague doing CTPA. So we're finding that we're able to get that message out even more clearly to our referring physicians because of the quality of the lung scanning that we actually obtain.